should be better. And if intuition makes sense, all marriages should go on as well. So simplicity is divine and reproducibility is mandatory. So if you can get a hostile neck done with simple technology, I think it's worth trying, and there's no evidence that suggests that it won't last long. So I think the data is still at large, the jury is still at large on that, but I appreciate his comments.
Yes, I have a question.
My comments, you asked my comments regarding?
No, just a question. Okay. In relation to what Arno von Risto presented, I think it's very, very interesting, but we had troubles with that, depending on how the credentials are given to the technicians. Obviously, this technique is related very closely to the operator, and how do you define who should do the case and what level of experience you should have or the technician should have to be reliable? Because we are not doing CT, just color duplex, so we have to be sure what you are doing.
Se eu entendi bem a pergunta, como é decidido quem deve fazer o exame, é isso?
Yeah, what credential you should have to be reliable?
Nós temos muito cuidado de selecionar quem são os ecografistas que realizam os exames. E muitas vezes repetimos o exame, caso nós tenhamos dúvida de que ele esteja bem realizado. Então, isso é fundamental. Como o ecodoppler é um exame extremamente examinador dependente, nós temos que ter uma seleção muito grande. E, com o tempo, essa seleção acaba sendo feita.
One question for the previous speaker who made a comment about simple devices, that we don't have data that they perform well outside the IFU or don't perform well. We do have data, and once you go outside the instructions for use for infrarenal devices, the Eurostar data says that you'll increase your type 1 endoleak and your failure rate, and that you create secondary problems for your patients, because then to do a repair becomes much more difficult for endovascular approaches, and you may then convert the patient ultimately to an open repair at a more advanced age. So we don't go outside the IFU. That's why we have IFUs for fenestrated and branch grafts, and when they meet those, we can reliably tell the patients what the results are. But I cannot tell a patient with a 90-degree, 10-millimeter neck that he's going to have a durable 96% 5-year freedom from rupture, because that data says that's not the case.
And absolutely agree with that. My intention was not to completely go out IFU. The data is compelling on out IFU data. Having said that, there's a couple of issues. Number one is the access to the technology itself, which you have, we don't. What to do with these large aneurysms while waiting for it. And again, these are patients that currently are not evaluated for optimal open repair, which should be offered on these patients because they are physiologically high-risk patients. So you are. The second comment on the Eurostar data is the technology, that the repositionable technology, which I'm supposed to be defending today, it is having, doesn't have a significant record on long-term performance. But I think if we intuitively, you can agree that infrarenal active fixation is probably as good as suprarenal active fixation. And maybe there is some data on renal function decreasing in suprarenal systems as well. There is some data from the clinic that suggests that. So if you can stay infrarenal, actively fixate, and avoid migration over time, and I think it's something that you could do, you should do.
Franchini, posso fazer uma pergunta?
Não, é uma pergunta rápida, porque nós fizemos em relação ao tratamento endovascular dos aneurismas rotos, a gente fez uma pequena mudança no protocolo. Quando esse paciente chega à tomografia, vai ao estudo tomográfico, nós primeiro fazemos a tomografia sem contraste. E se o radiologista identifica que aparentemente há um colo bom abaixo das renais, ele não usa o contraste, porque nós sabemos que na tomografia nós usamos até de 100 a 120 ml de contraste. E existe uma nova tecnologia em que tu colocas um cateter, um pigtail na aorta, e tu faz a angiotomografia com um volume muito pequeno de contraste. Então eu queria fazer a pergunta para a mesa se alguém usa essa nova tecnologia, que é a angiotomografia com um volume mínimo de contraste na seleção desses pacientes que apresentam aneurisma roto. Injeção intraarterial.
Não, absolutamente não, porque, na verdade, aqui no Rio de Janeiro, essas tomografias são feitas geralmente em centros específicos. O único lugar que eu sei que faz isso é o Gustavo Oderich, parece que foi ele que sugeriu isso, e eu vi alguns casos que ele teria feito isso, mas aqui a gente não faz especificamente isso, pelo menos.
The same for us in North Carolina. We only use it for renal insufficiency and elective cases.
Eu tenho uma questão para o Coselli, vê se ele está com fone. A question for you. A questão é a seguinte, na verdade aqui no Brasil a gente não vê muito pacientes com doenças do colágeno, espécie Marfan, são relativamente raros, mas eventualmente vemos algum. Eu sei que ele é uma das pessoas que tem a maior experiência no mundo, e a minha pergunta para ele é muito específica, se ele acha que tem algum papel o tratamento endovascular, seja tóraco-abdominal ou mesmo não, para o tratamento desses doentes com doença do colágeno.
Yeah, that's a good question, and the answer is that we do it selectively. Certainly the answer is that we do it. The answer is we do it selectively. For in a thoracoabdominal aortic aneurysm and a connective tissue disorder. Well, first of all, we don't have access to some of the branch graft technology, so from that standpoint, it's a no-brainer. But even if we did, and for descending aneurysms and some of the abdominal aneurysms, and with EVAR and TVAR, I would have to say that we do it selectively. We've used it on quite a few patients, though. We've used it for patch aneurysms at the intercostal level. We've used it for pseudoaneurysms. There's been some patients with connective tissue disorders that have grafts above and grafts below, and then we're spanning so that we're placing endografts bridging between two previous technologies, either sewn-in Dacron grafts or prior stent grafts. But I think with simple fenestration and some of these connective tissue disorders, we're going to be better off ultimately with the branch grafting in some of the connective tissue disorders, and particularly Marfan syndrome, where when you get away from the aorta and out into the branch vessel, the incidence of branch vessel aneurysmal disease is somewhat less common. But that's not true for all of the connective tissue disorders as a group. An example would be with Loeys-Dietz syndrome, where the branch vessel aneurysmal disease is just as common as the aortic pathology. So I think when we get into these some of these sub-selective groups of patients, that our individualization of our therapy is going to have to be very, very carefully considered.
Não, eu tinha uma outra pergunta. Na verdade, a gente sabe que na cirurgia aberta alguns pontos são muito importantes, como o shunt de átrio esquerdo para manutenção da perfusão de membros inferiores, o reimplante de artérias intercostais, tudo isso com o objetivo de você diminuir a paraplegia, e o Dr. Coselli tem no serviço talvez um dos melhores resultados do mundo nesse sentido. E, por outro lado, nós que fazemos basicamente mesmo o tipo 2 totalmente endovascular, temos um número de paraplegia, ou pelo menos estatisticamente do que já foi publicado, muito próximo. E não reimplantamos nenhuma intercostal, e, na verdade, o índice continua baixo. Então, é uma coisa que me intriga, do lado até positivo, porque é bom que a gente tenha um resultado bom e que tenha um bom índice de paraplegia, um índice baixo, né? Mas, ao mesmo tempo, eu queria saber como é que ele vê essa situação, como é que ele explicaria por que, mesmo excluindo todas as intercostais, a gente tem um resultado tão baixo de paraplegia.
We've seen the same thing. In an open operation, the physiologic insult to the spinal cord is different and no questionably more severe as a consequences of the alterations in flow and the ischemic times. The ischemic times in the endovascular coverage is minuscule, and it's simply the anatomic loss of direct circulation into the intercostal arteries that's affected. So you've got a multifactorial assault in the open operation, and as a consequence, our other institution and others have taken this multifactorial insult with a kind of a multifactorial approach to trying to reduce the risk. The risk in complete coverage of the thoracic and abdominal aorta without direct intercostal or lumbar artery reattachment is not zero with regards to paraplegia. Thus leads the discussion as to what's the role of such things as CSF drainage, pharmacologic management, the importance of postoperative hemodynamic and blood pressure management, and such things as staging our opportunities to allow for collateral circulation to alter itself over time, and how all these various things are going to play out. I think we're just going to need a lot more experience and a lot more data.
Vamos então abrir a palavra para o auditório. Por favor. 2 microfones. Alguém quer fazer alguma pergunta? À mesa? Alguém da mesa deseja fazer mais alguma coisa? Bom, minha presença aqui nessa mesa é uma presença quase histórica, muito mais que pela grande especialidade que é endovascular, apesar de eu acompanhar no Rio, Marcelo Ferreira, aulas, enfim, nesse aspecto da moderna cirurgia. Por que eu digo histórico? Eu digo histórico porque, na primeira apresentação do professor Parodi no Rio de Janeiro, eu fui o moderador e fiz várias perguntas a ele, inclusive, eu me lembro de uma, se faria em jovem, se a duração de material, quando ele apresentou os 7 primeiros casos. Depois, na segunda apresentação do professor Parodi no Rio de Janeiro, eu também moderei. E a nossa curva ascendente da cirurgia convencional, que era assim, já estava a endovascular subindo e a convencional descendo. E hoje em dia, como vocês viram as apresentações da mesa, a cirurgia convencional tem que existir, mas endovascular realmente é a primeira opção. Eu parabenizo a todos e gostaria que o professor Parodi terminasse a moderação com o seu conhecimento e seus pensamentos sobre tudo isso.
Thank you. That's not easy, but when I thought about my inventions, I thought that my best invention was the gastroepiploid coronary bypass. The endograft idea was initially, I thought that was just a dream, not feasible, at least with the technology we had initially in the 70s. But doing more and more operations, I came to the conclusion that the open operation is a great one, but it's too aggressive for these debilitated patients. And that's why I continued. No, it took me 20 years to develop the first endograft. And since then, I think we opened the door for everybody, like people here in the panel, to go further and to cover cases that we wouldn't be able to do in the past, probably with the use of percutaneous aortic valves. We can think that in the future we will be able to replace from the aortic valve to the groin or even to the lower extremities. The only problem we see with this extensive coverage, obviously, is paraplegia. On the other hand, we are learning that intercostal arteries, they form collaterals very rapidly in days, at least in animal experiences. And probably we will come with something like replacing a small branch like Krasi Ivansev is doing, leaving a small branch open to perfuse the sac for a month or perhaps a little more and then occlude that. Just based upon the animal experiments in which the development of collaterals after occluding the intercostals is very rapid. But I'm very pleased, I'm very happy that that dream came true, and today we are vascular surgeons doing this. Initially, I had a lot of people against me because they thought that it was a radiologist, but I think vascular surgery changed for the good, and we embraced the endovascular procedures very, very early. I'm happy for that. I am happy for the patients. A few months ago, we did a case with Marcelo, and it felt so good. The patient with a big thoracoabdominal aneurysm, we did it on the local, small groin incision and exposure of the subclavian artery. And the patient the following day, that was a type 2, the following day was asking me that to go home because he was just walking. And I couldn't believe that because we were doing extensive procedures, but when you replace a type 2 thoracoabdominal and the patient goes home the following day, that is almost a miracle for us. But it's a miracle that happens every day. Thank you.